So very good afternoon to all, and I want to thank Scientific Committee for giving me this opportunity. So I'll be speaking on compliance, adherence, and persistent, they give challenges in the glaucoma therapy. So is adherence an issue for glaucoma management? Yes, we know that glaucoma is a leading cause of irreversible blindness, and the first line of management in POAG is the ocular hypotensive drops, and patient has to put these drops for a long time throughout their life, and since it is an asymptomatic disease, so patient don't understand, they don't get any visual benefit, and therefore they don't understand why to put these drops, and therefore adherence, persistence, and compliance is a major challenge in treating glaucoma in these patients. And we know that non-adherence can lead to progression of the field loss, and patient can lose vision if they don't understand about the disease. And there are studies which show that 50% of patients are found to be non-adherent to their medication over 75% of the times. So it's a big challenge. So let us understand what do you mean by compliance, adherence, and persistence. So compliance means the extent of patient's behavior corresponds with the physician's recommendations. So patient says, yes, I am putting medications, I am using, so patient is cooperative. But adherence means active participation from the patient, means patient says, yes, I am taking medication exactly as prescribed and following the regime. So persistence is the most important challenge. And adherence is the most important, and persistence means length of time or duration for which patient continues to follow that regime. So patient says, I am taking medication as prescribed with correct dosage, correct eye, correct time, and for the duration it has been prescribed. So these are the things which are very important in medical management of glaucoma. So what are the barriers? Why patients not adherent to the glaucoma medication? So they are classified as into 4 classes. Can be patient factors, can be medication related factors, can be provider factors, or can be situational or environmental factors which cause obstacle in following the regime. So what are the patient factors? Could be a forgetfulness. So patient, they forget to put the drop. The regime is so complicated, they forget to put the drops, when to put which drop at what time to put the drops. So they forget to put drop, or patient may be having systemic comorbidities along with glaucoma, like the patient may be diabetic, may be hypertensive, patient may have some cardiac issues. So patient has so many medications to take, so patient doesn't follow the regime, or patient doesn't understand the disease. It is very important to make the patient understand what is glaucoma and what it is a vision threatening disease. The patient should know the importance of putting the medication. So giving knowledge of glaucoma, giving chair time to the patient, explaining the patient about the disease before starting treatment is very, very important in glaucoma. On top of it, patient may have poor manual dexterity. Patient may have tremors, may not be able to put the drops, or patient has a poor eye-hand coordination. Patient may have a poor vision, not able to see which drop to put, when to put. These are all factors which are patient factors which lead to poor adherence to the glaucoma management. Then there are medication-related factors also there. The complex prescribed to the patient is so complex. There are multiple medications, more frequency. The patient has to put 1 drop at once, other is 2 times, third is 3 times a day. So patient get confused. It's so inconvenient for the patient. So regime is related factor may be there. Or these patients have side effects also because of these drops. They may have ocular side effects, they may have redness, they may have allergy to drops, or they have side effects systemic also. Drowsiness is one of the important side effects. So patient may not like to put the drop because of these factors. Economical issue is the most important. It is there's a recurrent cost of medicine involved because they have to use drops for a longer duration of time. They have to buy the medicines every time, and they have costly medicines. So cost is an important factor, and sometimes patients who are residing in remote areas, availability of drug may be a factor. Doctors prescribe a particular brand, patient may not get the particular brand, and patient may stop using the drop because availability is not there. And we have seen this in COVID times when drugs were not available and the patient missed the dosage. Then there are provider factors also. There's a poor communication between the physician and the patient because the disease has not been explained to the patient properly. The rationale of prescribing so many drugs has not been explained to the patient. So patient is not satisfied that why he should use all these drops when he's not getting any benefit from putting these drops. There are environmental factors also for poor adherence, like patient is traveling job or patient is away from home, not able to carry the medication, there's change in his routine. There's a lack of caregivers are not there who can help him in putting the drops, or there's nobody to escort the patient for the follow-up to the hospital. That may lead to discontinuation of the treatment, or there's a lack of support from the family. There's nobody who understands about the disease and provides the medication to the patient. So there are so many obstacles are there in the medication. So there's a glaucoma adherence persistence study which identified following factors. There are many studies which have tried to find out what are the most important factors for poor adherence, and they found that cost is the most important factor. Patient not able to buy so costly medicines for such a long period, and forgetfulness in 32%, fear and denial in 16%, lack of understanding about glaucoma in 16%, and complexity of the treatment was in 15% of patients. So how do we find out, how do we assess the adherence, whether the patient is adherent or not adherent? Like we have prescribed the medication, patients come for follow-up and we don't know whether the patient is putting the drops or not putting the drops. So how do we evaluate the adherence to the medication? So there are direct methods and there are indirect methods of assessment. Direct method is that we observe the patient taking medication. So which is the most accurate method. So patients observe that patients putting the right time and right drop, or measuring the concentration of the drug metabolite in the blood and urine, which is very expensive, and this direct method is not feasible, it is cumbersome. So there are indirect methods also for assessing the adherence to the medication. Either it can be patient self-reporting, so patient reports, said that I am putting medication, and we can ask certain questions about the awareness of the disease, understanding of the disease, about the medication, which drop, at what time patient is putting. That is one method. Second is we look for the refill rates. How many drugs patient has used in the period, or measuring the amount of medication in the bottle. We see whether the bottle is full or it is empty, or we can count number of bottles patient used at the end of the month. These are all indirect methods. There are studies on utilizing electronic medication monitors also, like the Treviton dosing ad is there, in which through the bottle is a device attached to the bottle. Every time when patient presses and puts the drop, the device will record the time as well as the number of drops. Or patient can be asked to maintain a medication diary when the bottle was purchased and how many bottle has been purchased, when was the patient was putting the drops. These are indirect methods, but they are not very accurate, and no technique is without flaws. What we can do is, how do we find adherence is that we measure IOP and see whether what target pressure we have set, that the IOP is controlled in that range only, and whether glaucoma is progressing or it is stabilized. That is how we can assess the adherence to the glaucoma medication. But there is no consensus on which is the best method for measuring the adherence to medication. Then another syndrome is white coat compliance or syndrome. This is something very interesting. Some of the patient, what they do, they will start putting drops 1 week before they come for follow-up, and then they'll stop after that. So when a patient comes, you find that the IOP is normal within the range, but the patient is progressing. So it is very important to find out this, whether the patient is doing this, and this may lead to, we may add medication, we may change the medication, find that the patient is progressing, though the IOP is controlled. So we may think that this medication we are giving is not adequate, and we may add on more drops. And this will further complicate the regime, and this will lead to poor adherence. So we should be aware of this syndrome also. So ultimately, how do we address this problem of non-adherence? The most important thing is educate the patient about the disease, because many times patients don't know which disease they are suffering. They know that drops have been prescribed, but they don't know about the glaucoma. So teach the patient about glaucoma, tell about what is the disease, what are the side effects, what are the importance of putting the drop, and what will happen if the patient doesn't remain adherent. We can use educational videos, we can give some informative material to the patient to read, or personalized counseling can be done in the OPD. We can have counselors who can teach the patient how to put the drops, can tell about the disease, and can tell about the importance of adherence and compliance. Even educating family is also important, because they have to support the patient for this medication. And another thing is to simplify the regime, whatever we are prescribing. Give minimal number of bottles and minimum number of drops. Like we can choose a combination of the drops, and so that will help in improving adherence. We can set alarms also in the clocks or in the watches also. We can put some reminders so that the patient can put the drops. What else we can do is, there are certain other therapeutic options we can be opted, like we can do SLT. SLT will help in reducing the number of drops. So if the patient is using 4 drops or 5 drops, we can do SLT also in POG patients. That will help in reducing the number of drops. Or now MIG is also very safe, so that can also be done, either the stands or the KDB can be done. So this will also help in reducing the number of drops, thus simplifying the treatment regime. That will improve the adherence to the patient. And now the implantable devices are also available, slow release, which will also help in reducing the number of drops. So these are the few which can be added to. So to conclude, adherence to glaucoma medication is still a challenge, because patients to put the drops for a longer period of time without any visual benefit. And so patient education is the key. We have to educate the patient about the disease. They know why they have to put the drop. And we have to use a simplified treatment regime with minimal side effects. And we can add these regimes so as to reduce the number of drops, like SLT or mix can be added. Thank you so much.
Thank you, Dr. Saroj Gupta ma'am, for the wonderful presentation. Sir, any question? Ma'am, I would like to ask you, if the patient is on 3 drugs and patient is getting complaints of redness, congestion in the eyes, so should we continue with the medications or should go for surgery?
So we have to find out first which is the drug which is causing allergy to the drop. Right. And we can always change the molecule, And if we think we have to add another drug, then what we can advise the surgery also, either I said the mix or SLT, or we can even advise a filtering surgery also. Patient has a lot many side effects and IOP is not controlled. Or we can change the molecule also.
Yeah, you are right,
That
ma'am.
is will be done.
Okay.
Ma'am, have you heard about TUG? I
Yes,
asked the same
I
question.
read about this. Sir. This is a new
Have you ever came
Sir, I
across?
read about it. I read about it. The
You
ultrasound you said.
can you please use your mic?
Sir, I read about this therapy which you are referring to.
Yeah.
The ultrasound.
Actually, yeah. One more thing I want to add. It will cost you just 7,000 rupees.
Yes.
The tug machine which I converted from the dental scaler machine, it will cost you just 7,000 rupees. And in my study, I'm not a professor, I'm not attached with any college or anywhere. But in my private practice, I have observed 20 to 50% reduction of the IOP from the baseline. So adherence may become indirectly very much, and I treat my patient free of cost. It just costs me nothing. It's just 5 minutes treatment. There are some videos of my own on your YouTube, and you may go through the tug.
Is it available, sir, here in the?
It is nothing to like to available. You can modify this dental scaler machine, which is 6 to 7,000 rupees cost. All these machines works on 40 kilohertz ultrasound therapy. What Dr. Donald Schwartz observed, he observed that while doing phaco, there is reduction of the intraocular pressure. And what he suggested that phaco versus SICS, if the patient goes under SICS, there is no reduction of IOP or very minimal reduction of IOP with compared to the same patient if undergoes phacoemulsification. So the focal ultrasound energy cleans up the trabecular meshwork, and there is lots of another cytokinin effect also that reduces the intraocular pressure. So what he did, he made a ultrasound probe of 40 kilohertz, and he developed a machine. So from limbus, just below the limbus, he applied that ultrasound probe to this means guinea pigs and all these experiments, and he found that 20 to 50% reduction of the IOP was there. There are lots of papers also on PubMed and everywhere. So he designed that machine. So in 2014, I went to USA and I personally met Dr. Donald, but that machine was not possible to bring to India because of some other restrictions. So I thought and I worked on it, and I found that this dental ultrascalar machine, this comes with 40 kilohertz ultrasound piezoelectric crystals. One thing. Second thing, that machines, this dental scalar machine works at 30 to 40 watt power. In human, for any therapeutic ultrasound, we need just 2 watt of power. More than 2 watt is much more detrimental and necrotizing. So what I did, just change the power supply of original machine from 28 or 30, exactly I forgot, but it is there on my YouTube video. So I just 12 watt, 1 ampere power supply, and dental ultrasound, the ultrascalar comes with pointed tip, and I just de-sharpened it. I made it round so it doesn't hurt to the eye. And in my personal, and we 3 people have worked on it, myself and Dr. Kakadia, if anybody knows him, and Dr. R.C. Shah from Bombay. We 3 people worked on it. We found that there is a very good reduction of IOP. Even lots of painful blind eye people benefited like anything. So they were on the drops in blind eye, and they were not happy. And this is just you being a glaucoma specialist. I just want you to do some study and highlight it.
Yes, it will be good if it is available in the market. So
you just type dental piezo 2 piezo 2 ultrasound dental scaler. It's 6 to 7,000 rupees cost. You just change the power supply from its original to 12V 1 ampere power supply. And you just round up that means the point. There are 5 tips available with dental ultrasound machine. Out of any tip, you just make it round, polish, and your ophthalmic ultrasound tug machine is ready. It will cost you just 7,000 rupees, 7,000 rupees. And you being in teaching institute or somewhere, you can do more study on this thing.
Yes, so there are papers, I have gone through those papers.
There are lots of
yeah,
papers.
there are lots of papers
There are
on
lots
this.
of paper, and people are benefited.
Yes.
And practical, in my opinion, yes, they are getting
So it
benefits.
will help in reducing the eye drops
Eye-
and compliance will
and
definitely improve. So.
It reduces the eye drops, and suppose the patient is having 25 to 30 IOP, and if his IOP comes down to below 20, and if he doesn't put any drops for maybe 2 years, so he is off the drop for 2 years. My longest follow-up is 18 to 20 months. Yes. And almost most of the patients, they don't need drops if they are between 25 and 30. If they are 50, something like that, glaucomatous blind eye, then their pressure comes down to 25 to 30, and with one drop, they are happy. You know, and band-shaped keratopathy, and we get lots of other problems of high IOP.
Thank you so
So
much,
this
so much
is
for
my
your information.
observation. I thought I should share with you,
Yes,
and
yes.
no financial interest.
Sir, we have to apply it on below the limbus.
Yes,
Ultrasound.
1 millimeter away from the limbus.
Okay.
And
For how
there
much time?
Dr. Donald Schwartz applies it for 1 minute, 5 spot. So for example, lower half,
Okay.
1, 2, 3, 4 and 5 in lower half,
Lower.
or in upper half.
Okay.
Okay, and he repeats the same treatment, 1 minute each spot. He just putting the paracaine drops. That's enough. You don't need any injectable. I
Like
mean,
we do
yeah.
cyclocryo like that only.
It is exactly like cyclocryo, but you are
Okay.
not
Applying the
cryoing
cryo
or
probe?
destroying anything. You are
Okay.
just cleaning it. Some people named it traboclean, means it cleans the trabecular meshwork. And we know the theory of ultrasound. It is a very huge, there are lots of chapters on ultrasound. I read all these things.
It acts on ciliary body to reduce the aqueous humor. Like, do you micropulse cyclophotogalation we are using?
It is not micropulse. You need to do it continuously, but you need to put not more than 2 watt power. 2 watt is the borderline, because any therapy on human body, 2 watt is upper line. We are taking, ultrasound therapy for our achy muscles and all these things. All the machine works on 2 watt power only. If they increase the power more than 2, then it is damaging and necrotizing to the tissues.
Right.
So this is borderline.
Yes.
Thank
Sir.
you.